you for coming. My name is Dr. Qureshi. I'm an endocrinologist. I'm board certified in internal medicine and endocrinology. I actually practiced as an internist for about 4 years before I did my fellowship. So we'll be talking about what I see the most. I see other endocrine problems too, but see diabetes quite a bit, so we can cover other topics in our other talks, but today I just wanted to talk about a little bit about diabetes. And feel free to ask questions. We have time at the end as well to ask any questions. And the way I kind of did this talk is a little bit about the questions that my patients ask me and what are the answers that I gave. My clinic is in South Tampa. That's where I see patients, and I go to a few facilities, including the HCA South Tampa Hospital, and then some long-term facilities as well. Okay, so one of the questions that is asked quite often by patients, by people, and it can get a little confusing is, what is the difference between type 1 and type 2 diabetes, and why is it important for a diabetic to know what kind of diabetes they have, why it's important. A lot of times as a specialist, I see patients being misdiagnosed as type 1 when they're type 2 and vice versa. So it's the age doesn't matter. Children can have type 2 diabetes, especially if they are overweight, they have some other metabolic problems, they can have type 2 diabetes. And then adults can have type 1 diabetes. So it's not necessary that if a child has diabetes, they're type 1, and if an adult has diabetes, they're type 2. So there are different kinds of diabetes. For example, for type, it's not as common as type 2 diabetes, but there are adults who develop type 1 diabetes, and it has a long name, latent autoimmune diabetes of the adult. It's an autoimmune disorder, and they can develop the type 1 diabetes much later in life. Most of the type 1 diabetics are kids we see, who develop it in their teen years or as children. But there is something which is similar to type 1 diabetes in adults. So type 1 diabetes can be seen in adults, and type 2 diabetes can be seen in children. Any questions?
What is the difference?
We'll talk about what is type 1 and type 2 in the next couple of slides. Okay, so why is it important to know what kind of diabetes you have? So type 1 diabetes is a kind of diabetes. It's genetic. It can be autoimmune. Sometimes it can be a viral infection that can trigger it, that affects the pancreas, which is the gland in the body that produces insulin. It's important to know that type 1 diabetics are always dependent on insulin. So there is an insulin deficiency. The pancreas is not making enough insulin. And therefore, if they do not take their insulin for whatever reason, they can get something that is called diabetic ketoacidosis. It's a very dangerous condition. There's electrolyte imbalances. The patient have to be admitted to the ICU. So type 1 diabetes is always insulin dependent. So is type 2 diabetes insulin dependent? It can be. So what happens if you overwork something, right? Like it's a computer or a car or anything, it burns out. So with type 2 diabetes, what happens is that as the pancreas starts making less and less insulin, what's happening is the blood sugars are higher and higher, and the pancreas, it burns out, making enough insulin. So you may be started on one medication or two medications. Well, actually, your doctor may say, oh, you're pre-diabetic, for example, or you have early diabetes, and they can put you on, they'll recommend, exercise, make sure you watch your carbohydrates and sugars, right? and then put you on one medication, and it could be, you know, adding more and more. But eventually, what happens is, as the pancreas can no longer make enough insulin, your doctor's going to say, your primary care or endocrinologist, whoever you're seeing, that okay, I think it's time for you to be on insulin. So type 2 diabetes, type 2 diabetics usually start on oral medications and end up being on you know, insulin. So it's not, patients don't like doing injections. You know, insulin is injectable. Unfortunately, there was an inhaled form, but it doesn't work that well, but it's mainly injectables. A lot of times I see this reaction if I tell a patient, okay, you need to be started on insulin. Oh no, I don't want to be on insulin. I want to stay away from insulin for as long as I can. Insulin is a safe medication. It's what your own body would be making if you were not a diabetic. Insulin, we'll talk about this another slide. Insulin is safe. It's given to pregnant women. It's given to children who have diabetes. So it's, all the medications have side effects too. But there are times when you do need to be put on insulin. And now with all these, actually I was telling Lisa, I was here a few years ago, so I had prepared a similar talk, and then there's so many, new drugs and new things that have come out since I've been here. So there's so much going on in terms of the research and what the new medications are, that when previously people were either not diagnosed with diabetes or they were dying from the complications of diabetes. Now they're living longer and longer because the diabetes can be controlled with these new medications, and with how we are monitoring the blood sugars, and I'll talk about that a little bit more, the continuous glucose monitoring. So people are getting to live longer without the complications affecting their life, and therefore they eventually may end up on insulin because they're living longer, so they're getting to that stage of the disease that they need the insulin. So the other question, sometimes if I start a patient on insulin or they're already on insulin, they would ask that can we go off the our insulin. So it depends on it depends on a lot of factors, how much insulin you're taking, how long you've been a diabetic for. But the bottom line is always talk to your doctor before going off insulin or making any changes to your medications. Like if you feel like your blood sugars are doing good, and you need to decrease a medication or decrease the insulin, that's important to talk to your doctor and never go off. So I just added that at the bottom of the slide, that like I remember I told you if a type 1 diabetics go off the insulin, they can get into trouble because they can get what is called diabetic ketoacidosis, and it's a very critical condition. They have to be in ICU and IV insulin and things like that. But even with type 2 diabetes, there is something called hyperosmolar coma. Like if your glucose is like 8 in the 800s, for example, right? If it's really, really high, it can affect so many things, and it can lead to a similar condition. So it's very important that any medication changes or any stopping or decreasing, you always discuss with your doctor. So can type 2 diabetes be reversed? Yes, it can be reversed. Again, it depends on how long the patient has been a diabetic, and what they have been taking. So if a patient is extremely overweight, for example, and they lose weight, or they start exercising, or they start eating right, it can be reversed, meaning they would still need their blood sugars and labs to be monitored at least once in a while, but they may be able to go off their medications. We'll talk a little bit more about nutrition. It's very important about what diabetic patients eat or don't eat. So we always we don't just look at the sugar contents of food. We look at the carbohydrate contents. I don't know if you guys have heard of intermittent fasting and keto diets. These are lifestyle modifications that can help reverse diabetes. Where I trained in Kentucky, at University of Kentucky, and they actually had a program which was a meal replacement. Like so, it was a supervised weight loss program for diabetics. So it wasn't just for regular people, but high risk patients who were on a lot of medication. So that's why we, as trainees in endocrinology, and our doctors, our attendings were involved. I've seen patients go off like 100 units of insulin to nothing, just controlling it, with the diet, with the meal replacement plan, and just a good meal plan. So it's possible. And then the last one of the indications for somebody having sorry, can you go back to the piece? I'm still on. Thank you. Okay, so one of the indications I'm sure you guys would have heard of or know someone who's had a gastric surgery, like there's a bypass, sleeve. Those are invasive procedures, so there's a lot that goes into that decision if somebody needs that. But one of the reasons is if somebody, it's not just somebody who's just overweight, but if somebody is overweight and because of that they have type 2 diabetes, for example, high blood pressure, high cholesterol. So after the surgery, their diabetes can be reversed. So we spoke about whether the type 2 diabetes can be reversed or not. What about diabetic complications? Can they be reversed or delayed? And the answer is yes. That's exactly why I'm here giving you guys a talk. That's why doctors take care of your diabetes. That's why we prescribe medications and help you take care of your diabetes, because the purpose is to get blood sugars under better control and to avoid those and delay those complications or even stop them from happening. So if any of you have diabetes, I'm sure you would know that your doctor will send you for an eye exam, once a year at least, right? Or check for protein in the urine, because these are the complications from the diabetes. It can affect your eyes. It's one of the leading causes of blindness in adults. And it's very silent, like you wouldn't really have any symptoms till you go to the eye doctor and they do a dilated eye exam and they say, oh, you have changes from diabetes. So there's another slide. So you don't really always feel your low or high blood sugar, not always, and that's why it's important if you're diabetic that you're getting monitored. So there are patients that they get diagnosed that they didn't even know they had diabetes, because remember, if your blood sugars are high, you don't really feel too much symptoms, so you just can't go by symptoms. But they go to an eye exam for like a regular eye exam, and the doctor will say, oh, I see changes from diabetes. And guess what? They've been a diabetic for at least a few years to have those complications. So the complications, the eye complications, the kidneys, diabetes is one of the main leading causes for renal failure and for patients going on dialysis. So that can be reversed and it can be prevented. And in the last few years, there have been some new medications that they've been here for a few years, but now that they have done studies to see how much protection they have allowed in terms of all these complications. But I don't know if you guys have seen, I'm sure there are ads for medications like Forxiga and Jardiance. Those are the relatively newer medications, and they actually are protected. They protect the kidneys from the effects of diabetes. I have patients, sometimes I see, and they will come to me and say, oh, our heart doctor or our kidney doctor is asking us if you can put us, in addition to whatever we're taking, if you can put us on Forxiga or Jardiance, because they offer that protection for the heart and the kidneys. So the controlling the diabetes, of course, getting your blood sugars under control and being on the right medications can reverse these complications for sure. Any questions? So the last one.
Excuse me.
Yes.
What is low blood glucose? I know nothing about this.
Yeah, sure. Just give me, sorry. Okay. So, I'm going to come to that right after the slide, okay? Thank you for your question. Okay, so again, coming back to the point, can you, if you're a diabetic, can you feel if your blood sugars are high? Not always. And the diabetes is a silent killer. That's exactly the point, that you may not know you're a diabetic or how your blood sugars are, because you're not always going to have a pain or something to tell you. Now there are symptoms that patients will sometimes present with, that we feel thirsty a lot, we drink a lot, we eat a lot, but it doesn't always happen, and it can be missed. So high blood sugars are always not necessarily felt, and that's why it's important to check your blood sugars, and we'll talk a little bit about the devices that are out there for continuous glucose monitoring. The continuous glucose monitoring, there are devices. I would think that you guys know someone who's on, hopefully know someone, or maybe you're on it yourself, or have seen ads about Freestyle Libre and Dexcom. These are continuous glucose monitors, and they substitute for checking finger sticks. Finger sticks checking your blood sugar, it can be painful, it can be inconvenient, it can be tricky. So these continuous glucose monitors, you can wear them, you change them every 10 days or 14 days depending on which device you have, and they actually have alarms. So the doctor will set alarms for you, and sometimes they have automatic alarms, and the doctor can change it, that if your blood sugar is higher than a certain number or lower than a certain number, you may or may not feel it, but the alarm will there will be an alarm, or there will be a noise that'll alert you that your blood sugar is too high or too low, and you need to do something about it. So I already mentioned that sometimes people, because they don't feel their high blood sugars or feel that they have diabetes, you can actually have already a complication of diabetes, like for example, in the eyes, a diabetic retinopathy, before you even find out you're a diabetic. So, okay, so a low blood sugar by medical definition is a blood sugar that is 70 or less. So for gold blood sugars, I know a lot of my patients, unfortunately, nobody has discussed the basics with them. So a good blood sugar for, a gold for blood sugar is 120 or less for fasting, and about 150 to 180, random or after meals. Anything above that is considered a high blood sugar. A low blood sugar is when your blood sugar is 70 or less, and you can have symptoms. So you can be sweaty, shaky, dizzy, hungry, just feel like you're panicking. But that being said, there are patients who have what is called hypoglycemia unawareness. And what that is that patients don't feel their low blood sugars. So it usually happens when a patient has been a diabetic for a long time, but it can happen to anyone. So they may be as low as 40 and not feel a thing. They may not have the symptoms of being sweaty, shaky, dizzy, hungry, and that unfortunately is a complication of the diabetes itself. It affects the nerves and all the mechanisms that is going to prompt you. So what happens when you have a low blood sugar? It's like a stress response, right? Like all the stress hormones in the body. That's why you feel like you're under stress, like you're panicking. But all those mechanisms can be affected if somebody is a diabetic, so they may not have those symptoms. For example, in diabetics, this is just giving you an example. Patients can have had heart attacks and may not have had chest pain at all, and then they go to the doctor and they find out that they've had a heart attack. So diabetes leads to silent heart attacks, silent MIs, because you lose the feel. You can no longer have those symptoms. So it's all this is all the neuropathy from the diabetes. That's a complication of the diabetes, and it affects the way you feel the pain, or the nerves. Like I'm sure you may know someone who has a diabetic neuropathy. They have the numbness, the tingling. So they either have no feeling or they are, hypersensitive to certain things. So, and all these are complications from the diabetes. So similarly, if a patient has been a diabetic, especially for a while, they may not feel the low blood sugars. So that's why the continuous glucose monitoring devices or checking your finger sticks is very, very important. Any way, whether you're checking your finger sticks or doing the continuous glucose monitoring to check your blood sugars, that's very important. Yes.
When you check your blood sugars, how often would you recommend we do that a day?
That would depend on what you are taking for your diabetes. If you're taking insulin, if you're taking medications, we typically recommend, the more you check, the better, right? But there's a catch to it. Medicare and other insurances, they unfortunately dictate to us how often you can check and how many fingers, how many strips they're going to cover. So the rule for typically most insurances, if you're not on insulin, they will only cover one strip at the most a day. We can try to bypass it and say, patient needs to check and, a certain number of times. But if you are on insulin, then it becomes at least 3 to 4 times a day. And then we'll come back and talk about the continuous glucose monitoring. That is continuous. Because you can use your reader that comes with the device that you're wearing, or even your smartphone, and you can swipe and check it every minute if you want. So because it's continuous. You're welcome. So so one more thing, which is a very basic information, but as I said, unfortunately, a lot of doctors, they may have shared, but patients forget. When you have a low blood sugar, right, when we say, okay, it's 70 or less, and you're having symptoms, and you're not having symptoms, but you check and it's low, it's very important to treat it. But what happens is that, patients panic. Like, it's not a good feeling. If you feel it, if you don't feel it, you wouldn't even know. But if you are having the symptoms, it just is like an impending doom, something bad is happening. And they panic and they overtreat. So they're gonna just have candy and juice and this and that, and, just grab whatever, they can get their whole hands on. So it's important not to overtreat a blood sugar. There's a science to it. There's something, I don't want to confuse, it's a lot of numbers out there, and that's something that, when you see a doctor, hopefully they should have told you, or they can tell you, and you can ask them, we call it a rule of 15. So you take, if your blood sugar is low, you take 15 grams of carbohydrates, which could be half a cup of juice, 1 cup of milk, glucose tablets, that are over the counter. You can, each of them is about 4 grams, so about 4 of those, or the glucose gel. So you need to take the 15 grams of carbohydrates and recheck in 15 minutes. If it's still low, then you can take, more. But it's important not to overtreat. So one of the things that's very important, what I try to tell patients, like if you're on medications, right, or you're on insulin for your diabetes, and you're having to eat more, and you're afraid you're going to drop, what are you going to do? Are you going to keep eating? For example, somebody's having low blood sugars in the night, when you're sleeping, and that's a really bad time to have low blood sugars, because even if you feel the symptoms, you're sleepy, you're not completely alert. The key is you don't eat more. You try to decrease your medications. That's when you talk to your doctor. And that's why it's important to check your blood sugars, because you can say, hey, I'm having low blood sugars. I think I need to cut down on my medications, my insulin, or whatever I'm taking. So you don't chase your insulin with food. It beats the purpose. You're gonna gain weight, and then you're gonna, if you overtreat your low blood sugars, you're never gonna have good control, right? Because it may be 70 and you overtreat it goes all the way to 300. So that's not good. So it's always important to control your low blood sugars and treat your low blood sugars before you control or treat your high blood sugars. I think I actually have another slide on this. Okay, do symptoms of a low blood sugar mean that you have a low blood sugar? Not always. So remember I told you there are some people who don't feel any symptoms at all with the low blood sugar. Sometimes I have patients, we were feeling low, we thought we had a low blood sugar, so we just, had a cup of juice. What if it wasn't a low blood sugar? Because if you don't check, you just had a symptom from something else, And if your blood sugar is normal, now having the cup of juice is going to shoot your blood sugar to really high. So it's very important to check. So check. There's no substitute. Whatever, do a finger stick, continuous glucose monitoring, but checking is extremely important. Is it good to have low blood sugar? Blood glucose is lower better? How low is low? So we already discussed how low is low, right? Like a 70 or less is with symptoms is having a low blood sugar. I do want to share something because I go and see patients in the hospital, and usually the patients in the hospitals have very, very high blood sugars. So if somebody has had high blood sugars, say in the 200, 300s, 400s for a long time, when they can start feeling symptoms of low blood sugars when they are normal, because the body is so used to those 300s and 400s. If they're in the 200s, they'll say, oh, we feel we're low. It's not really low. It's just that it's going to take the body some time to get used to that. So low is not always better, especially in older people with other medical problems like heart disease, stroke. There are a lot of studies that have been done that low blood sugars can actually be detrimental. And because low blood sugar can lead to a seizure, it can lead to a stroke, it can cause so many problems. So the goal is not to have a low blood sugar. The goal is to have a normal blood sugar. All right. So it's very important, and that's why I said it's always, as a doctor, as an endocrinologist, if I'm seeing a diabetic patient, I always talk to my patient first about, are you having low blood sugars, and we try to fix that problem and then focus on the high blood sugars, because it's not good to have low blood sugars. We already discussed, what is a goal. Fasting should be about between 90 to 120, and random blood sugar between 150 to 180. Does anybody know what a hemoglobin A1C is? Yes.
Yeah, I know what it is.
So a hemoglobin A1C is a test that your doctors are going to run on you every 3 months, maybe in 6 months if you're well controlled. It's a blood test, and it tells you what your average blood sugars are in the last 3 months, right? So but here's the thing: this is not your report card. This is just a snapshot. It's a lot of importance is given to this A1C. I see patients like, oh, our eye doctor just wants to know what our A1C is. Yeah, that's good to know whether it's high or low. But remember, it's an average of your blood sugar. So if you're having a lot of low blood sugars like 40s, and you're having a lot of high blood sugars like 300s, what is the average going to be? That is going to be a good number, right? But that doesn't mean that your diabetes is well controlled. So the important thing is to have normal blood sugar levels and not just focus on the hemoglobin A1C. And that's coming back to the point, checking your blood sugars, sharing those numbers with your doctor. That's very, very important, because A1C, unfortunately, insurances ask us, like they actually, ding doctors if the patient's A1C is, above a certain number. But there's so much that goes behind that, right? It's not just the A1C. It's making sure that your blood sugars are not like a roller coaster up and down. They're more in the normal range. So the blood sugars that you check is way more important than just an A1C. An A1C is just a number. It could be normal if you had high or low numbers. So, do oral or non-insulin medication need to be stopped when insulin is started? So this is more like, I'm obviously being a specialist. I see patients who are I may see more patients who are more advanced in their diabetes, and the question comes, okay, they are on, say, metformin, and you're on glipizide or whatever medications you're on, and now your doctor say, okay, you know what, we can no longer control it with these medications, we have to put you on insulin. So it depends on what medications you are on. You may or may not need to stop it. So metformin, for example, works very well with insulin. It helps the insulin work better. It decreases the insulin resistance. The other medications, there's GLP-1, which you may have heard of. There's Victoza, Bydureon, Trulicity, Ozempic, and then they can be used with the insulin. Sometimes you may have to decrease the dose if you get put on insulin, But there are medications that can work very well with the insulin and work together in a synergistic effect. They all work in different ways. One of the medications that is not my favorite, and I see a lot of patients on it, and I try, so are sulfonylureas, which is a glipizide, glyburide, I'm trying to think of some other names, but that class of medication can cause low blood sugars. So I can't stress enough how important it is, for us to take better control, better care of our patients with diabetes so that they don't have low blood sugars. Because I go to hospitals, I've seen patients who took, like, for example, their glipizide 3 days ago, and they still are having low blood sugars in the hospital. So some of these medications have very long half-life, so they last in the body for a long time. And with older people, if your kidneys are not working 100%, your liver is not working 100%, that's how the medications are processed in your body, and your body gets rid of it and metabolizes. Those effects can be 3 times more, right? So instead of the 1 day, it's going to last for 3 days in your body. So it's very, very important to be on the right medications. And sulfonylureas, they cause your, the reason why patients get put on it, it's cheap, it's generic, most insurances cover it, most doctors, it's been there forever and ever. So the newer medications, unless you are, have a specialist like myself, an endocrinologist, or your primary care doctor who's, has a lot of diabetic patients, and they're keeping in touch with all the up-to-date information and research, the doctors may not know. Every doctor knows about sulfonylurea. There's no way you can, graduate out of med school without, you don't even have to be a medical doctor, you can be a surgeon and they will still know, because it's one of the oldest drugs. But yeah, it's not the best medication for everybody, and if you get put on insulin, I always stop that medicine, because the risk of having a low blood sugar increases a lot. One of the questions, I think I told you that I was trying to just kind of, base this presentation on the questions I get asked by patients and other people about diabetes, so trying to cover those. So one of the questions I get asked is, does metformin, is it going to cause us to have kidney failure? Metformin does not cause kidney failure. Metformin does not cause liver failure. There is always some information that comes out that metformin does this, metformin does that. One of the things is metformin is free at Publix. I don't know if you guys know that, but you can get it completely free at Publix. It's a generic medicine. It's for $4. You're not going to see any ads about metformin in any of the TV commercials, because nobody's making money on it. It's a generic pill. It's been there forever and ever. It's a great medication, but it's not for everybody, and that's why you need to be, seeing a doctor and those conversations. If you have a kidney dysfunction, like your kidneys aren't 100%, your creatinine, which is a level which assesses your kidney function, is above a certain number, like 1.3. You may not, you shouldn't be on metformin, or you need to talk to your doctor about it. If somebody's kidney function is stable, they can still be on metformin, but if it's getting worse, or it's just, gotten there, you're probably not the right candidate for being on metformin. Metformin itself doesn't cause kidney failure, but if somebody has kidney failure or they have poor kidney function, they shouldn't be on metformin, and the reason being that metformin is cleared through the kidneys. So if your kidneys are not working 100%, the side effects are going to be more. Now this goes for, and that's why it's important to have a doctor follow you for this. A specialist or a PCP who specializes, or at least has a focus on diabetes. When your kidney, most of the medications for even insulin, and most of the medications for diabetes, if your kidney function is in a certain level, like say it's stage 1 kidney failure, or stage 2, stage 3, whatever it is, these medications need to be what is called, we have to do renal dosing. It's based on your kidney function. And that's what a doctor can do for you. They can calculate, oh, this is your kidney function. Okay, you were taking this dose of this medicine, for example, Januvia. It's one of the medications. So the maximum dose is 100 milligrams, but based on the kidney function, your doctor may only give you 50 or 25. So that's something that we have to pay attention to. So so when people get started on insulin, the question is always which kind, how many, injections. This is what I do, right? So I can talk about this all day. But just to give you a brief, overlook, there are a lot of different kinds of insulins. Depending on what you need and what your insurance covers, we can get you on the right kind if you need. We can start with one injection. Some patients may need more. So there are different there are different regimens for insulin, and that's where your discussion with the doctor who knows you, who's going to start you on it, can discuss what is the best option for you. There are premixed insulins which are given twice a day. I don't see a lot of doctors use that because it's cheap. Where I trained, we had a lot of indigenous people come from different really areas, remote areas, because we were like the biggest city and university center. So one of these insulins, it's actually at Walmart. It's available without a prescription. It's called Rely on Insulin. So, but a lot of doctors are not going to tell you about it or put you on it because they may not even know about it. So, I've been fortunate to train in a setting where I've seen all kinds of patients. So we had a lot of experience with that. But for example, if it's a patient who's going to lose their insurance or whatever, and they know that they can't afford it, or insulin's getting too expensive, we can give them that option. It's like $25 for one bottle of insulin. And sometimes you can even get it without a prescription at Walmart. So there are a lot of options out there for what kind of insulin, whether it's one injection or 2 or 4 or 3 or whatever, and your doctor can always work with you. So does insulin cause diabetic complications? Not at all. It actually prevents diabetic complications by getting your blood sugars to be better controlled. Is insulin safe? Yes, insulin is very, very safe. Some of the medications can have side effects, but if you're on the right dose of the insulin and you're not having low blood sugars, there is no other side effect of the insulin per se. And I was just going to stress on the point, if a woman gets pregnant and she's a diabetic, or she is on insulin, we continue the insulin. Insulin is safe in pregnancy. A lot of the medications we cannot give, so it is safe. And so it goes for children, with type 1 diabetes who get diagnosed at a really young age. So if insulin wasn't safe, they wouldn't be getting the insulin. So insulin is definitely safe. One of the questions, so when we start somebody on some of the medications, so there are medications for diabetes that we call weight neutral, and some that cause weight loss, and some that cause weight gain. Insulin doesn't cause weight gain directly, but remember, if your blood sugars are very high, like they're 200, 300, you're drinking and peeing all the time, you're losing muscle weight. So when you put that person on the medication, which is going to control their blood sugars, whether it's insulin or another medication, they may stop losing that weight. So they're not really gaining weight, but they stop losing the weight. And it's not a good way to lose weight by having high blood sugars, right? It's a catabolic state. Your body is being like, you're losing muscle weight essentially. Anybody has questions about that?
Yes. I went insulin 3 years ago. I've gained 40 pounds.
So there are a few factors, and I can, I don't want to take too much time, but there can be a few factors. It's not you may have been losing weight or not gaining when you went on insulin. You probably went on insulin because your blood sugars were not very well controlled, right? That's why your doctor must have decided to put you on insulin. So then you stop losing that weight because your blood sugars are better controlled. Sometimes if you're on too much insulin and you are having the low blood sugars, remember we spoke a lot about low blood sugars, what happens is you're afraid and you're going to eat a lot to keep up with that insulin dose, and that's not right. So if you have a lot of low blood sugars, and or you're afraid you're going to have a low blood sugar, say in the night, and it's a valid fear, it's a valid concern. You're gonna just eat. Okay, I'm gonna like you're gonna. And not you, right? And anyone like that. Like the patient will say, oh, I'm gonna have a snack because I want to make sure I don't have a low blood sugar. Now you may not be hungry, but because you're afraid of a low blood sugar, you're gonna have a snack at night. So all those things are calories that's going to add. So if you're having low blood sugars, you can actually gain weight because you're going to overtreat yourself. Remember the slide I showed you where your blood sugar is low and you panic and you eat or drink and your blood sugars, goes all the way from 40s or 50s to 300s. So there could be multiple causes for that, and there could be other causes too. Did your doctor check your thyroid levels? Making sure that everything else is okay. So I don't necessarily know that it's your insulin that's causing the weight gain. It's either you're having low blood sugars and you're not on the right regimen possibly, and that needs to be reviewed, or there could be other causes. But if you were not on insulin and your blood sugars were really, really high, you are not going to gain weight, you're actually going to lose weight. So that's what insulin does. Did I answer your question?
Yes, thank you.
You're welcome. Yeah, so it's very important not to have low blood sugars with insulin, and talking to your doctor about changing your regimen if you're having that.
Pardon me,
Yes.
question. If you're on both insulins, how come we never hear about the premix?
Oh, okay. Remember I spoke about the premix. The premix insulin is a cheap insulin. You don't see any about ads and stuff. So the premix insulin is twice a day. So it's not the best insulin for every patient. If you are like a regimen, like you eat breakfast, lunch, dinner, same time every day, like you have a scheduled time, then you can be on premix insulin. Premix insulin is it's a combination, right? It's a long and short-acting insulin together. So there are advantages and there are disadvantages. If somebody needs to be started on insulin, for example, right? Like if you're already on it, it's different. Say somebody who's never checked their blood sugars, never taken anything, and now tell them, oh, you know what, your hemoglobin A1C is 10 and your blood sugars are 300, and we have to put you on insulin. If I put them on 4 insulin injections, do you think they're going to take it? No, it's going to be very, very hard. You have to be practical. So it's good to start the 2 shots a day because it's the long and short acting together, right? But because you have to take it before breakfast and before dinner. If it's a person who's eating at different times, or they have a some weird work schedule or something, like working in the night, sleeping during the day, it's not going to be the best insulin for them. But if you're on a regimen, you can talk to your doctor about it. It's the downside. The good side is it's only 2 injections versus 4 injections if you're taking like the long acting once a day and the short acting 3 times a day with meals. The downside is you can't really adjust the dose that much, right? Like if your blood sugar is low, like you only want to like decrease the short acting insulin and not the long acting, but how are you going to do that? It's a premix, it's already mixed in a ratio, 70-30 or 75-25. So, but you can have that conversation, with your patients. I have patients, I started on premix insulin and they have done so well that we didn't need to change them to anything else, and they've stayed on the premix insulin. Actually, one of them, he gets it from Walmart because for whatever reason his copay is so high with the insurance that he just finds it easier and cheaper for him to get it, the premix insulin from Walmart. And they also have it in pens now. But yeah, that's a discussion you can have with your doctor. And as I said, a lot of doctors don't have experience in premix because I have a different experience, like I was dealing with indigenous people in my training, and then they used to give these insulin actually for free. So a lot of patients may not know about, doctors may not know, they may know of the more fancier insulins that are out there. So every patient is different, right? Every thing is different. So that's something that you can always discuss with your doctor. Okay. Sorry, Lisa, there's the first step in treatment of diabetes.
Which number is it?
Is it the pre?
Okay.
Yes. Thank you. Okay, so what is the first step in treatment of diabetes? Is it medications or insulin? The answer is no, it's lifestyle modification. So the first thing is controlling your diet, exercising, and diabetes education. That's what I'm here for. There are certified, I'm not a certified diabetes educator, I'm an endocrinologist, but there are, certified diabetes educators. Most insurances, including Medicare, covers that. So talk to your doctor. I mean, if I have a patient, like I will refer them for diabetes education. And this is a very, it's not a 1 hour talk like am I coming and talking to you guys. It's like, it's extensive. Like they have like 8 hour classes that you do in like 2 days, or you do once a week or whatever, but they can talk to you about so many things and give you so much more information. And it's never too late to have that education. You can always learn, you can always, do something better than what you're doing. So it's very, very important. And so talk to your doctor about that, about seeing a diabetes educator. But yeah, the first step in controlling your diabetes, even if you are on medications, is still to do it right? To understand what the insulins are, what the medications are, how to control a low blood sugar, what a low blood sugar is, how to take care, what to eat, what not to eat. So it's the first step is diet, exercise, diabetes education, and then of course, depending on what you need, the medications and the insulin. Okay, so sorry, next one. Okay, so thank you. Do we look at sugars? Do we look at the total for a day? Is sugar-free okay? Anyone wants to share what they have questions or want to share anything about this? So when we look at labels, right? A lot of my patients have never had a proper diabetes education class. And they've been diabetic for years, they've been in the hospital for diabetes, they're on insulin, they're on all kinds of medications, but nobody has really told them about the basic things, and that's why I say it's never too late. It's very important that the diabetes educators, they will tell you about nutrition, but there are nutritionists too, and there are programs, out there. There's so much information. There's like handouts or paper information. Actually, next time I come, I forgot. I'm going to bring some with me. But when you look at like labels for food, what you're eating, you don't just look at the sugars. You look at the total carbohydrates. Every carbohydrate is converted into sugar in your body, and it's going to increase your blood sugars. So not to get it too complicated and too confusing, but you do look at labels. Or everything is not labeled, right? What you're being served, so you can read about it, or you can have a general idea. Like a slice of bread, for example, is 15 grams of carbohydrates for most breads, right? There are others that are more, there are others that are less, and depending on the size, of course. But it's important to look at labels. So it's important not just to say, oh, we're not going to have desserts, we're not going to have sugars. You can still, be having a lot of carbohydrates and increasing your blood sugars without unknowingly. I'll give you an example. My dad is a diabetic, and he became a diabetic after I trained everything, and I mean, like, he doesn't live with me, so I don't really have this conversation. One day he was having like he likes bananas, and I'm like, I told him, I said, this is a lot of carbohydrates. Like, do you realize banana is not the sweetest food, there can be, of course, cherries and grapes. We know that's a lot of sugar. It's natural sugar, but it's still sugar. But bananas are full of starch, so they are going to increase your blood sugars quite a bit. But nobody had told him, and he'd never thought about it. So I see a lot of patients like, we had a banana and oatmeal for breakfast and milk. All that is carbohydrates. So you can have it, but not stop. Nobody is going to say don't eat the carbohydrates, but you have to limit about how much you eat. So there's it's about so when I see patients in the hospital, right? It's hard to obviously do this when I seeing patients in the clinic. In the hospital, the doctors can order their diet, right, based on what their conditions are. So if they have heart failure, we restrict their salt, or they have kidney failure, they're on a renal diet, So for diabetics, we do what is called a carbohydrate consistent diet. What that means is that you get the same amount of carbohydrates with each meal. Typically, the allowance is 30 to 45 grams or 45 to 60 grams with each meal. Now, what does it mean? So it doesn't mean that you're going to say, you know what, I'm not going to have my 45 grams of carbohydrates with lunch. I'm just going to have a salad with with chicken, and there's no dressing, so there's no carbohydrates. But I'm going to make up for all those carbohydrates at lunch, at dinner, by having a big bowl of pasta. Is it going to work? No, because you know what? Your blood sugar is going to be so high after dinner. So the important thing is having the same amount of carbohydrates, or trying to, with each meal, instead of not having any at all for one meal, and then kind of having a whole bunch of them for one meal. Does that make sense? Yes.
What can you tell us about the sugar-free sodas? What would be considered too much, or what's okay?
So there's a whole debate about sugar-free stuff. Sugar-free. There's always there's the natural ones now. The stevia, which are supposedly more natural, and then there's the sucralose. The studies have shown that when you do moderation is the key, right? Like if you take too much of anything, it's going to be bad for you. So what happens is, if you have too much of the sugar-free stuff, it can stimulate your appetite, and then you feel more hungry, you eat more, and your sugars go up. So you can have it, but you have to have it in moderation, and be careful about that. So sugar-free is not always okay. It's obviously I'll give you an example. I'm a tea drinker. I don't really drink coffee. I drink tea, and I drink a lot of tea. I don't add sugar to my tea, because if I were to add sugar every time, or a sweet, like a sugar-free substitute, that would be a lot, because I'm having like 3, 4, 5, 6 cups sometimes, of the caffeine. So I just started having it without anything, without a sugar substitute, and without sugar. So I think it's for example, and I'm going to give you an example that I always think of. He was a younger patient, and he came to me for his diabetes, and hemoglobin A1C was like 9 or 10, blood sugars in the 300s, and he's on insulin and everything. And we're talking like, hey, what happened? And he had labs before, and his glucose had been fine. So suddenly something changed, like in the last few months. And he's like, oh yeah, I drink. I'm like, what do you eat? What do you drink? I drink. I go through a whole. I don't know how many cans are in like a whole box of like soda. Like I just drink that all the time. Like, you realize how much sugar you're drinking. That's what's causing your diabetes. And he actually this patient was able to go off his insulin in a few months, because all he did, the only change he made, was stop the soda. Because that's water or unsweetened beverages are really the best. If you want to do sugar-free, just be careful, and do it in moderation. And I'm not going to go to the next slide, but yes.
What do you consider moderation for sugar-free sodas? Do you consider?
So maybe 1 or 2 in a day. Oh, yeah. Sorry, can you go back? Okay, I hope you guys didn't see my slide. So does anybody know how many teaspoons of sugar are in a 20-ounce soda?
I know it's like a third of a cup. I know it looks like a third. My son is a dentist, and he has a bottle, an empty bottle,
Yeah.
and the bottom of it has that much sugar.
Yeah. So can you go to the next slide? So 16 teaspoons of sugar. So even thinking about it makes you sick, right? Can somebody sit and eat 16 teaspoons of sugar? But that's how much these sweetened beverages have. So I feel that, for the most part, patients are not eating that many sugars, but they're drinking more sugars. And you're right, it affects your teeth, it affects the diabetes, it affects so many things. And you know what, if you eat something, right? So I'll give you an example. So and this is a whole field in itself, and I can talk about it like on its own, about nutrition. But so for example, if you have pizza, right? So pizza is the carbohydrate, the crust is the carbohydrates, but it also has the cheese in it, which is the fat. So the way your body absorbs the carbohydrate with the fat, it's going to increase your blood sugar, but it's going to increase it gradually and it's going to stay high for a while. What happens when you drink something like that, or when it's going to shoot up your blood sugar immediately? And so that's why even if you're having a low blood sugar and you're going to have like some soda or juice to control it, it's going to correct it, but then it can come right back. So when somebody's having a low blood sugar, I tell them, yeah, it's okay to take the sugar to get the 15 grams. Remember the 15 grams? This is so this is 16 multiplied by 4. So how much is that? 32, 64. This is 64 grams. So 64 grams, right? And you only should be taking 15 grams to even if you're having a low blood sugar to control. To treat that. So but yeah, that's how much. So the sweetened beverages like the sweetened tea, the sodas. This is very lemonades because it's tangy or whatever, right? So they have to add a lot of sugar to let it taste sweet. Any questions about this? Yes.
I went from fat-free milk to soy milk. Was that a good move?
That's a totally different thing. I mean, was it because you had some allergies or? So the soy-free milk still has carbohydrates in it.
Oh.
So from the diabetic standpoint, it's not necessarily something that's that important. The fat content, of course, of the milk is high, except if it's fat-free, right? But I'll have to look. I don't know what the carbohydrate content of soy milk is, but typically we don't recommend unless you have an allergy, like you're lactose intolerant or something like that, to go to a different kind of milk. But milk, whatever it's soy milk or almond milk or regular milk, even fat-free milk, right? Fat-free just means there's no fat in it. They all do have carbohydrates, so you have to look at the labels and see, how much carbohydrate is in it. I can look it up and let you know. Yes.
Is there a limit to how much water you should drink in a day?
It depends on what your other medical conditions are. So from diabetes, not really, but if somebody has congestive heart failure, right, or then they need to limit the amount of fluids or salt that they're taking. From the diabetes standpoint, no. You can drink, but yeah, what are your other medical conditions? That's if you just had diabetes, then no.
Yeah, because I'm supposed to drink 96 ounces of water a day, which is a tremendous amount of water.
Yeah, that's a lot.
Right.
Yeah. So not from the diabetes standpoint. Okay. Are non-insulin medications safe? So we already spoke a little bit about insulin, how safe it is. So every medication has side effects, and that's why, your doctor, you can see an ad and go and talk to your doctor. Hey, I saw this ad, and what do you think of this medication? So you can always, I encourage my patients to ask me questions and any questions or concerns they have, because, maybe I overlooked something or, something changed, right? So talk to your doctor if you have any questions or concerns about any of your medication. Every medication, unfortunately, has side effects. So in terms of what are the medications, so we already discussed a little bit about metformin, right? Metformin has, the people who can't tolerate it get really bad GI side effects like diarrhea and, things like that. And they've had to stop it, for that. And we try, there's an extended release medication we can put them on. There's a brand medication called Glumedza. There are other options. Trying to take it with food is important because some of my patients, nobody's ever told them to take metformin with food. And I'm like, yeah, that's a basic thing. You have to take it with food. Otherwise, you're going to have really bad side effects. But that basic information has not been shared with them. So, sulfuride ureas I already told about. They can cause low blood sugars. I'm not saying that nobody can ever be on it. But if you're doing okay and not having low blood sugars, you can stay on them, but just be careful. You need to know how the medicine you're taking works, because if you understand that, then you'll know what side effects it can cause. There's a medication called Actos or pioglitazone. If somebody has very high, not cholesterol, but high triglycerides, for example, this medication can help with that and the diabetes. And also if somebody has fatty liver, and patients with diabetes can have what is called non-alcoholic steatohepatitis or fatty liver in plain words, and that medicine can actually help with that. So it depends on the patient, right? Every patient is different. So what are your other medical conditions? What is your lifestyle? So you have to consider so many things when you make these decisions about choosing the medications. So GLP-1 agonists, these are injectables and not pills. They started with a medication called Victoza, which was once a day. There was Byetta, that was twice a day. And now they have these once a week medications. They're not insulin, they're injectables, but they're not insulin, and they're once a week. And sometimes patients may need just one shot of insulin and this one medication, once a day. They help with weight loss. They actually, in higher doses, they are given specifically for weight loss to patients, even if they're not diabetics. And I'm not going to go into how they work, but yeah, it's important to just kind of have an idea that, so the DPP-4, so the GLP-1, like this is Victoza, Byetta, Bidori, or Trulicity, Ozempic, those are the common ones. There's actually a medication which is a combination now, which is Lantus, and one of them is called Soliqua. So that's one shot a day, and you're getting actually 2 medications. It's not a premix, but it's like 2 medications together. It's an insulin along with a GLP-1. So it's great because in one injection, you're getting, 2 different medications that work in 2 different ways. The DPP-4 medications, those are weight neutral. They don't cause you to gain weight. They don't cause you to lose weight. That's like Januvia and Tradjenta. Those are the common ones. They are very safe. They are much safer. In older people, especially if your the kidney function is not 100%, and it's a pill. The SGLT2 inhibitors, this is a relatively new medication, and actually just came out when I finished my training in 2013. So it's been 9 years actually. Wow. But in this time, the way they work is they make you pee out glucose, so it can cause some urinary tract infections, vaginal candidiasis in women. So it's very important that your doctor is going to talk to you about whether you're the right candidate for it or not. And I always, if I start a patient on anything, I always tell them about the side effects. So they are aware, right? And you can go and read a lot about it, but just letting them know of the basic things that, hey, if you start this medicine and you have a urinary tract infection, you need to let me know because we may need to stop it. But coming back to this, the SGLT2, this is one of the 2 things that in the last few years have really changed a lot and have helped, take care of diabetic patients for us as physicians. Is the SGLT2 medications. Like I have patients whose heart doctors and kidney doctors are going to say, can you ask your doctor to put you on this medication, because they protect the kidneys, they prevent heart failure, they protect your heart. So they are very good medications. So definitely talking to your doctor about putting you on these is going to help. And then so we already discussed the diabetic complications. I'm just gonna quick. So the complications from diabetes don't have any symptoms, right? You may not know that your eyesight is being affected and you have retinopathy before it's too late, and you have like a bleed in your eye and you're like totally blind. So that's why it's important to monitor for these things. Same thing for if your kidneys are not working well, you may not have any symptoms. It may be picked up on when your doctor orders like a urine test or a blood test. So we already discussed how diabetic patients can have a heart attack and may not have the chest pain and may not even know, and they have an EKG at the doctor's office. They're going to have like for example, a procedure, and the doctor wants to do like a pre-operative clearance, and they have an EKG, or they go for something else, and they see that they've already had a heart attack because they didn't have any symptoms. So the complications don't have symptoms. So that's why diabetes is called a silent killer, and that's why it's important to, monitor your blood sugars and be on the right medication and have it treat. So that's why it's important to take care. Next slide. That's why it's important to monitor for the complications. If you're a diabetic, make sure you're getting an eye exam once a year. You're getting your doctor's checking the urine for protein, for any damage to the kidneys. Foot exam is very important. Every diabetic should be checking their feet themselves every day. Keep a mirror or have someone else look at it. If you can, bend over and look at the back of your feet. Make sure there's no breakdown. If you can see a podiatrist, see it's not necessary, but obviously if you have a problem, see one. Taking care of the blood pressure, the high cholesterol. The cholesterol goals in diabetes are different than for cholesterol, right? For total cholesterol or LDL, which is a bad cholesterol, the goal for a diabetic is the same as some. So we have, everything has a goal, right? There's no one size that fits all. So every patient is different. So if somebody had a heart attack or a stroke, and they are seeing a heart doctor or even the primary care doctor and say, okay, now your LDL, your bad cholesterol needs to be 70 or less. What if they didn't have a heart attack, if they didn't have a stroke, and they're only a diabetic? Their goal is still less than 70 because diabetes is we call it the equivalent of heart disease. If you don't have a heart disease, you have all the risk factors for having heart disease or a stroke if you're a diabetic. Checking the thyroid is very important. So as an endocrinologist, I'm a thyroid specialist too. I do my own ultrasounds and biopsies, and the secondary to diabetes, the most of my patients, and of course I see other stuff, but I see patients with thyroid problems. It's very important. Diabetic patients can have thyroid problems, so make sure your doctor is checking like a thyroid test at least once a year, at least. I want to talk more about the continuous glucose monitoring before we finish, so I'm not gonna, but insulin pumps they deliver insulin. They're different from the continuous glucose monitors, and they don't check your blood sugars, but the good part is now there are insulin pumps that talk to the monitors. So you don't even have to check and put in your blood sugars, and the insulin pump will work for you. So we're talking about, has anyone heard or know anyone or used themselves a Freestyle Libre 2 or the Dexcom? What do you use?
Libre 2.
Okay, and you like it?
Yes.
So it's a continuous monitor, right? Do you want to share your experience with others? Like what do you like about it? Like,
I got it sitting right here next to me, waiting.
and you can check right now what your blood sugar is, right?
Well,
absolutely. So the continuous monitoring devices.
78.
Okay, so that's a little bit low. So maybe you need to have lunch soon, right? Okay. But here's the thing. See, so the continuous glucose monitor, the Libre 2 is one, and then there's Dexcom, and there are others too. Most insurances, depending on what medications and how often you check your blood sugars, will cover it. There is some paperwork that the doctor would have to do. Like I do it all the time for my patients. And even if, and I will tell you, and guidelines do change. So for example, Medicare wasn't covering it except for patients who were taking 4 insulin injections a day. Now, you don't have to, if you are on insulin or medication, then you do it all the time, you can. But say you're a pre-diabetic or you have very early diabetes and you're just on life, you're just controlling your diet or taking metformin or just one drug. You can still use it for 2 weeks, and that data can be shared with your doctor. And they can make changes based on that. So knowing what your blood sugar is all the time, it's amazing, right? Like you, without even checking your finger stick. You can use a reader like this, or you can be if you have a smartphone, you have an app on your phone, so you don't even need to have a reader. Your phone becomes your reader and stores all the information. So whether it's the reader or the phone, the download can be shared with your doctor. And it can be shared, like if you're doing it, like I've done a lot of televisits, because of COVID, like a video and audio visit where patients, were not like really physically coming in the office, and they could share the data. So I had all that information So this was such a blessing that, you know, they don't have to bring their meter and, you know, the piece of paper. I mean, they can always read out the numbers to me or email it to me or, you know, fax it or whatever. But we could do like the download. Actually, next time I'm going to show you some downloads. I completely forgot. But what they look like. So they tell you what your blood sugars are doing all day. Like while you're sleeping, while, you know, right after you eat, right before you eat. And you can check all the time. If your blood sugar is high, you give yourself insulin. And you want to check if it came down, you know, check again. You don't have to, you know, prick yourself to do that. So it's useful, it's painless, and that's what I said, that even if you don't need to wear it like all the time, or your insurance is not covering it, you can even sign up to get a free sample from the Abbott company. Like you have to fill out some paperwork, your doctor can do it for you, and you can just do it for 2 weeks, and maybe you can do it for 2 weeks every 6 months to see, you know, where you are if you don't want to do it all the time. But it's a very it's very useful information. So does everyone with diabetes need to see a diabetes specialist and an endocrinologist? So I practiced as a primary care physician for 4 years before I went to do my fellowship in diabetes. So I can tell you, obviously, I am a specialist in this field, and I do know more than a primary care doctor. But you know, your primary care doctors, especially if they're seeing a lot of diabetic patients, they're pretty good about it. But the bottom line is, everybody doesn't need to see an endocrinologist, but it cannot hurt. I mean, if you're seeing a specialist in a field, you know, when I did primary care, my focus wasn't just diabetes, right? I had to take care of, make sure the patients had a colonoscopy, they had a mammogram, they had their flu shot. I have to take care of so many things. I couldn't just focus on one thing. The good part is, as a specialist, I can only focus on that one thing and take really good care of it, because I don't have to worry about the other things, because the patients have their primary care to take care of. So it can really hurt to see, and especially if you want a second opinion or consultation, you don't have to see. I mean, some of my diabetic patients, if they're really well controlled, I can just even see them twice a year, or, you know, on an as-needed basis. So it's like, you know, you're having two, you know, physicians taking care of the same problem. And I will be honest, as a specialist, as an endocrinologist, obviously we have to attend the conferences and keep in touch with all the new research, all the new things. So your primary care doctors will find out about them for sure, and they will use them. But you know, we usually get to know all that, you know, sooner, just because that's our field, right? So okay, so we already spoke quite a lot about this. So the continuous glucose. Sorry, what's your name?
Dave Eshelman.
Dave. Okay, as Dave, you can talk to Dave if he wouldn't mind about his experience, because he's using it, so he can tell you first-hand experience about how life-changing using a continuous glucose monitor can be. You know, so it's painless. I mean, you insert it, and if you guys want, actually brought a couple of samples to show you guys what it's like. You just insert it in the arm, and you change it every 2 weeks, right? And it's because you're wearing it 24 hours, you can check with the reader, like Dave has a reader, or if you have a smartphone and you choose to use your phone, you can use that to swipe and check your blood sugar. So it's as simple as that. You know, you're going out to eat, right? And you forgot to take your meter and your strips or something like that. I mean, you know, if you have a smartphone, I actually encourage patients to use a phone even more than the reader, because at least my generation and the younger generation, they don't want anywhere without their phones, right? So like your phone is your life. So you have your phone with you all the time. You don't even have to carry something else. And the Libre 2, and now they have a Libre 3 and also Dexcom. They have alarms. Dave, do you have the 14-day or do you have the Libre 2? Do you have the Libre 2? Do you have the one with the alarms?
Yes.
Okay, so that's so helpful, right? Because the alarms can be set, because remember how I said that sometimes you may not feel the low blood sugars, or you may not, and you will never really feel the high blood sugars. So you can set the alarms on that, on your continuous glucose monitor, so that if you drop below a certain level or you are above a certain level, it'll alarm you. Sometimes alarms can be irritating because it'll go off too often and patients will silent it. But it's a very, especially for people, who don't feel their low blood sugars, which can be extremely dangerous, right? I've had patients who've had a car accident because they didn't feel the low blood sugar and they just passed out and, whatever. So bad things can happen. So it's such a great device that you can have the alarm set. And, I already discussed that most insurances will cover it, or you can just get a sample and at least kind of see, feel how you feel about it and get put on it. So there's no reason why nobody can be on it. It can only help. It can't hurt you. Knowing what your blood sugars are like. Like I'll give you an example. You eat something and you're not sure what's going to do to your blood sugar, and you have a Libre, right? Or a continuous glucose monitor, like a Dexcom or Libre, and you check and you're like, I ate this and my blood sugar shot from 100 to 300. You're going to be careful about doing the same thing again, or you limit the amount you eat or what you eat. So you're helping yourself. It's not even your doctor telling you. Knowledge is power. You know what your blood sugars are. So, and then lastly, I want to share. So these devices, the Dexcom and even the Freestyle Libre 2, you can share your information not just with your doctor, but with other providers. You have so with the doctors, for example, right? You have an issue with your blood sugar, you can call, like for example, if I have a patient, then they can call, and they don't have an appointment or they're whatever. Like, hey, can you look at my download and tell me what's going on and I need help? Do I need to make an appointment, or can you give me some feedback, right? So I can look at them without their physically coming to the clinic, because they're sharing the information, so I can see the information. Or you can share it with a family member, with a spouse, with a friend. You can share it with a caregiver. You can share it with, kids with type 1 diabetes, right? Who are in school, for example. They share it with the parents or their teachers. Even, kids can, okay, the alarm went on, whatever, it's a low blood sugar, they don't do anything about it, whatever, they're busy playing, whatever. But that other person will also get that alarm, so they can alert, if it's a parent, they can call the school, hey, my kid is having a low blood sugar, can you, whatever, take care of that. So it's very important. I have actually a patient, she's 70 something, so she has, remember I discussed how some old people older people can develop adults as something like type 1 diabetes. It has a different name, it's called LADA, but that's what she has. She doesn't feel her low blood sugar. She's had a fall and a fracture because she doesn't feel her low blood sugars, and her blood sugars are very brittle. So we got her the continuous glucose monitor with the alarm, and it's been a life-changing event for her. We purposely set the alarms at a higher number. So when she's for example, Dave is, 78 is still okay, right? 70 is a low blood sugar. So for her, for example, because she doesn't feel it coming, so if it drops quickly, so we, for example, set her alarm at 80. So she would have the alarm go off, so she knows that now it's going down and I need to do something, I need to eat something or be careful. So it has changed her life completely. So, yeah, we already went through all this, sorry. Okay, recommendations, lifestyle modifications, diabetes education is never too late. There's no substitute for checking sugars, so finger stick or continuous glucose monitor, talk to your doctors, go see an endocrinologist like myself, we do this all the time, put people on continuous glucose monitor. Next slide. Okay, so again, there are multiple, we already discussed that you can use a reader or your phone, and there are a few out there, few different kinds that are out there. Next slide. Okay, so just hopefully I'll be coming here, again soon and talk about other topics, because diabetes is a top, it's a field in itself. You can see, so I just kind of wanted to tell you guys what I do. So I don't just do diabetes, that is obviously the bread and butter of what I do, because diabetes is unfortunately very common. But I see patients with thyroid disorders. I have an endocrine certification in neck ultrasound. I do my own ultrasounds and biopsies. I actually, I brought my machine, I'll show you how small it is. I can do ultrasounds by bedside. It's mobile. Everybody doesn't need one, but for those who need it, I do it myself instead of you're going to a radiology department. High calcium, if your doctor's ever told you if you have a high calcium, it is probably worthwhile to have the discussion that do we need to see an endocrinologist. High calcium can be caused by primary hyperparathyroidism. It is a common disorder, and especially if you grow older, it is common. Calcium is checked in every blood work that you get done. It's part of the basic metabolic panel. So the doctors, they may not be checking especially for calcium, but it'll be part of that panel. High lipids, I actually have 2 patients in the hospital now I'm seeing, and their triglycerides were like 2,000, and they had pancreatitis because of that. So as an endocrinologist, I treat that as well. Any adrenal problems, pituitary problems, osteopenia, osteoporosis, steroids, if you have been on steroids for whatever reason for a very long time, if you need help getting taper, like it's very important that you can stop steroids unless you've been on it for like a burst, like just like a short while for asthma or something. If you're on steroids for a very long time, it would be very helpful that you see an endocrinologist because they can help you, taper off the medication. I think that's, so thank you for your time, and happy holidays in case I don't see you.